So it looks like we have, you know, most folks in, we'll probably have a couple more trickle in. So I'm gonna get us started. Hi, everyone. Our Big 10 teams, welcome to our August workshop with Smart Health Innovation Lab. I wanna introduce our panelists today, and then I'll hand it over to Kim to run the rest of the panel, and I'll insert myself, you know, for any questions that pop up. So Kim Ireland and I have gone back for a few years. I met her in my last role at Blue Cross Blue Shield Association. She's CEO and board chairperson for the Smart Health Innovation Lab. She also has another role. She has a day and a night job at CIO of Clio Health and Aspire Ventures. Kim is just a fountain of knowledge around health IT and, you know, what does it take to implement technology solutions in a healthcare system. And then Corey Meyer is VP of Health System Strategy for iLab, as well as the Director for Strategic Acceleration at Penn Medicine Lancaster General Health. And he represents the provider side of the house. And then we also have Jan. I'm not even gonna try to say your last name. I think it's Nina Sofa. And she is a health system strategist with iLab, and she's also with Lancaster General Health. We are missing Stacy today. She had a conflict, but I'm sure that Ben will represent Capital Blue Cross very well. He is a peer strategist at iLab, and he's also, his day job is a senior business development consultant at Capital Blue Cross. I'm glad these guys, even though they would be very well qualified to be your judges, are not, because everybody with the exception of Ben is a Penn State alum. And so we're glad that they're not having to rate these teams. And with that, I'm gonna turn it over to you, Kim, to get started.
Sure. Hi, everyone. Welcome. Hopefully y'all can hear me. So I'm just going to start off before we jump into the panel and give you a little bit of background about the Smart Health Innovation Lab, so that you know who we are and kind of give you some perspective on the answers that we'll be giving today. So the Smart Health Innovation Lab actually was founded back in 2016 when my boss, Assam Abadir, started to work in developing healthcare technologies under Aspire Ventures. And as he was building these healthcare technologies, it became clear that there was really, healthcare was really hard to get adoption. And so he went to some local partners, Penn Medicine, Lancaster General Health, and Capital Blue Cross, and said, let's work together and let's create an innovation lab where we can foster these ideas and we can really help these companies commercialize so that we can solve problems here in our local community. What's unique about our structure is that we actually are equally owned by all four partners. Clio Health is actually an Aspire portfolio company that I'll talk about in a few minutes. So oftentimes when you look at the different accelerators or innovation labs across the country, oftentimes we see misaligned priorities. So if they're typically owned by a payer or they're owned by a health system, you'll see that the problems that they're trying to solve are one-sided. And so our structure is unique. We think we're the only ones in the country that are kind of set up this way, where we have venture capital, health system, and payer, and a technology innovator all coming together to solve the problems. Okay, just checking. All right, so we're going to try to make this a little interactive today. One of the things that we wanted to start with, you know, the reason all of our founders were able to come together was because they shared this common goal, and the goal was really trying to solve the problems of the quadruple aim of healthcare. So I wanted to put up a poll question to see if you guys knew what the quadruple aim was. So Nana, if you could help me put that poll question up. There we go. So go ahead and choose. This is multiple choice. Choose all that apply. But what do you think are the goals of the quadruple aim? I'll give you a hint in case you missed it. There will be 4 goals. So go ahead and vote now, and then we'll see what you think. All right, hopefully everybody had a chance to vote here. All right, very good. So while we all would like to make healthcare free for everyone and we would all love to rid the world of COVID, those are unfortunately not two of the goals of the quadruple aim. So as we look at our goals here at the lab, we really are focusing on trying to find technologies that improve both the patient and the provider experience. And so this isn't just the doctors and the physicians, it's anybody that's in the healthcare system that's providing care. We really want to improve the population health. Again, that's why the shared goals of our local community with Capital Blue Cross and Penn Medicine, we really wanted to start first in our own backyard and solve problems and improve the population health here, and as well as reduce costs. We all want lower healthcare costs overall. So, all right, well, we'll keep going here. So let me just give you, we did talk about that, a little bit of background about Aspire Ventures. So as Nan mentioned, I do work for Aspire, and I am in charge of the management of the lab. But Aspire is a private equity firm. We are quite different than your typical VC company. So we're not the company that gives you as a startup cash and says, we'll see you at the next board meeting. We're really hands-on, and we really focus more on as a startup boundary. So we offer our portfolio companies shared services to allow them to kind of accelerate their growth. So we don't think all of our portfolio companies should have to have HR, finance, and they all should have to develop the Facebook login from a technology perspective. We offer all of those types of services to help accelerate their growth. Some of the companies there are some of the early portfolio companies that Aspire has that are in the healthcare and engagement space. Clio Health Go is, as I mentioned before, is a portfolio company inside of Aspire. It is a digital health platform and really focusing on how can we change the patient experience. My founder, Assam, that I mentioned earlier, his background is in all mobile tech. So one of the first products that Clio Health created was the Clio Go. And this is a mobile app that currently is being used for personal health concierge medicine inside the Penn Medicine HealthWorks healthcare offering. It offers health coaching, goals tracking, care navigation, and something that we're working on currently is payments disruption. The idea with the innovation lab is that with the technologies that come through, they can also then leverage the platform of Clio Go in order to give them a jump start into customers as well. So I'm going to pop it over to Corey here for a minute to just tell us a little bit about Penn Medicine LGH.
Thanks for having us. Just a fun fact about Penn Medicine. Penn Medicine was founded by Ben Franklin 250 years ago. So I like to say we've been innovating for 250 years. Not many organizations have been around that long. You can read some of the stats on the slide, but very proud of our number 4 best hospitals in PA. And we're the western front of Penn Medicine. We're a regional health system based in central Pennsylvania, and we have around 10,000 employees, and very complex, large health system. So a lot of opportunity. Pass back to you, Kim.
Great, thanks, Corey. I'm now going to turn it over to Ben. Ben, if you can just give us a little bit of background on Capital Blue Cross.
Sure, and thank you for having us. I greatly appreciate the opportunity to present some of our knowledge to you. Capital Blue Cross is one of 35 independent Blue Cross and Blue Shield companies across the country. Collectively, we insure 107 million members. So roughly a third of the population has some type of Blue Cross Blue Shield coverage. And that includes all 50 states and the District of Columbia and Puerto Rico. Capital Blue Cross itself operates in 21 counties in South Central Pennsylvania. We offer a full array of products, including medical, dental, vision, and stop loss programs. And most of our subsidiaries operate up and down the East Coast. And so often you'll find us in probably in your neck of the woods in one way or the other.
Great, thanks, Ben. So those are the little bit of background about the 4 founders. So just want to dive into a little bit more about the Innovation Lab. So we actually sit alongside of a venture fund called the Aspire Ventures Precision Medicine Fund. And the Aspire Ventures Precision Medicine Fund, which is AVP, was really designed to kind of invest in technologies and startups all along the path here. So if you're, very early on, I think a lot of the work that you guys are doing falls very far on the left side here, where it could be tech transfer, R&D type of stages. The Innovation Lab is meant to sit alongside the AVP and really be that commercialization arm. So oftentimes you'll find in healthcare technologies don't get fully adopted across the market because they don't have the expertise and the knowledge of the inside workings of a health system or a payer, and they can maybe not get insurance reimbursement. So on the left side, those are really the things we're focusing on, is how do we get these products commercialized and ready for adoption. This helps de-risk our investments from an investment perspective, because we're kind of guiding the companies through the process and ensuring that they will have a product at the end that the customer will want. So as I mentioned, our mission is really to help that fast track validation and adoption. Oftentimes that end piece can take years for companies, and we really try to do it in less than a year. There was one thing that, we are a startup ourselves. As I mentioned, we're only a few years old. So early on, I would say with our technologies that we were looking at, we were a little bit more on the opportunistic side. So we were finding cool technologies that were in spaces we thought we wanted to look at, orthopedics or behavioral health. But what we failed to do was actually go and find problems that needed to be solved. And so we've really shifted over the last year. And COVID kind of helped us really take an internal look at the programming we were offering and really dive into what problems needed to be solved, and that then can have that impact of the quadruple aim that we had talked about earlier. So if you are an entrepreneur in healthcare tech, you're going to be faced with many different locked doors along the way. And so these are just some of the different areas or hurdles that you may come across depending on what your technology is. It's oftentimes that you may know somebody in the C-suite, but you are really invested in a workflow that won't work clinically. And so these are the pieces and parts that we kind of can help with. We're going to pop up a second poll question. So wanted to kind of just set some reality. So what we wanted to know is if you guys have any sense of what percentage of healthcare startups actually fail within the first 4 years. And I think all right, hopefully everybody had a chance to put an answer in. You are all very correct. Did you get the cliff notes ahead of time? So yes, let's let me go on to the next slide here, and I'll show you. There actually is 56% of healthcare startups fail within the first 4 years. So oftentimes they can get through the initial seed funding and maybe get themselves into a Series A, but if they don't have that right product market fit or that path to clear adoption, they often will run out of money and fail. So that is what really we focus on here at the iLab, is really helping to unlock all those different doors and making sure that you're having access to experts like Corey, Jan, Ben that are on the phone today, as well as their full teams inside the payers and the health system, so that we can help guide you along the way. We've changed our focus again a little bit, so we interject a small micro pilot or a payer health system pilot in the early on to learn about how the product would be adopted just on a small scale, so that we then can look at what would a larger scale rollout look like, what is that full path to reimbursement, and then that hopefully would open up to our whole network. These are two companies that were in our inaugural class. Movi is a company out of Montreal, Canada. Their product was called NEKG. And EKG is actually a device that you put around your knee and you walk on a treadmill. And what it does is it measures your knee while in motion to understand why you may be having pain. Happy to say that they are deployed inside of Penn Medicine LGH, and they are getting a lot more of US-based commercial adoption. And so that was something we also helped them understand, was how the rules and regulations in Canada are different in the US, and really helped guide them to be successful here. And Neuroflow is another success story. Neuroflow is a behavioral health platform that went through our inaugural class, and they are currently being offered to the Capital Blue Cross members as a behavioral health consumer-focused solution, so that they can monitor depression, anxiety, and really have tools to keep them safe, especially during the pandemic. What we're looking at for fall 2021, so again, we shifted focus in early spring of this year. We sat down and we decided one of the areas we wanted to look at was dermatology, and really the struggles and challenges with access to dermatology, to dermatologists or to dermatology solutions. And so we put out an RFI, and we're in the late stages of actually finalizing the selection of who will be chosen, and we'll be rolling that out this fall. So that's a little bit of background about who we are. If there's any questions about that, or we can move right into the panel if you would like. Okay. All right, well, we'll start with the panel. I have my esteemed colleagues that will have to answer my questions.
We are ready.
I switched all the questions, Bunny. Just kidding. So really our focus today for you guys is we want to talk about healthcare innovation, product adoption, commercialization. We want to talk about the idea of accelerators and really how do you work with a health system, a payer, and ultimately get to that point where your product is adopted. So the first question I have for you guys, and I'm going to kick it off to Ben first. What do you feel are some of the top barriers that stifle innovation in healthcare?
Yeah, I think the number one thing that is a barrier, has been a barrier in the past, is really what prompted us to start this lab in the first place, and that is the direct competing priorities of a payer versus a provider, right? Often what is beneficial to one is directly a hindrance, or makes it difficult for the other one to adopt the technology. We have cases of companies that have come to us in the past that have said, I'll Penn Medicine, I'll get you X times revenue if you put this technology in, and then they come to us afterwards, and we have to say, well, that's not such a good idea for us because we're trying to lower cost or the usage of certain technologies in order to be good stewards of our customers' money. And so I think that is one of the major barriers in healthcare today.
Great, thank you. Jan, what about you? Any barriers that you see working on the innovation team? Oh wait, hold on, let me see if I can unmute you. All right, Jan, I think you're still on mute. There, oh wait. There you go.
Okay, can you hear me now?
Yep.
All right. So internally within the health system, there's a lot of barriers with competing projects. A lot of the projects that come through the innovation team involve IS, information services, utilizing their resources. So there's that, but then also the organization as a whole also has other priorities. For example, right now we have a priority within the community to help the community become lead-free. And then we also have a huge multi-million-dollar emergency department construction, and also a new proton therapy that's being installed in our Cancer Institute. So with that, and adding the unpredictable variable with the current environment of the pandemic. It's hard. It's hard to be able to innovate. But yeah, that's why we have this accelerator program to help.
Yeah, great. And so a good job opportunity is project management inside of a health system with all the projects you guys have been going on.
Mm-hmm.
But Corey, what about you? What do you think are some of the top barriers?
Well, I was just going to mention, your initial question about the quadruple aim and the wrong answer of ridding the community of COVID. One positive of COVID was we definitely prioritized during that time. And it was like the entire health system was focused on COVID related projects. And I've never seen projects get done so fast. And, unfortunately, that's not reality. As we're, getting out of COVID, hopefully out of COVID at some point soon, like Jan said, prioritization is always the issue. I like to use the analogy or tell the story of the emergency department, right? So we have 120,000 visits a year. We have, traumas coming in, and we're trying to innovate, right? It's like the old analogy of driving down the road going 80, 90 miles per hour, trying to change the tires at the same time. So, although there's always a time to innovate, it's very difficult when there's lots of priorities going on. So I think that's the number one thing. The second thing I think in healthcare is just the industry, right? There's so much compliance and regulations like HIPAA, and every industry has complexity, no doubt. But it's just healthcare is very complex compared to most industries. And then I would say the third thing, which I'll just briefly touch on, is that most larger health systems have spent a lot of money on electronic medical records, like Epic, like Cerner. And, often when we see technologies come in or innovations come in from the outside, we always need to look to see if our EMR vendor is looking to do it. And, you have to make the decision, will the vendor come up with that technology fast enough, or will this technology that we're hearing from a vendor, be the right fix? Although we have to spend money on that, right? Because a lot of times the EMR vendor will say, hey, this is free if you use our version of whatever the technology is. So that's just I'll call it a headwind to technologies that we always look at.
Yeah. So Corey, you mentioned COVID and how it created focus, but how has innovation and new things been really affected by the pandemic?
Yeah, I mean, I think people's focus have been on COVID. So I think it's hard for, innovators and new technology to even get a conversation with, very busy folks. But on the flip side, technologies that have been able to help us immediately with COVID have been, put in quicker than they would have ever been put in, pre-COVID. We stood up a very new technology within, 2 months, and it probably would have took 2 years based on, in a non-COVID environment. So, again, there's positives and negatives. I would say that be persistent, but be aware that the person you're trying to reach or get in front of in healthcare is likely at the worst point in their career, unfortunately, with stress and healthcare workers are tired, right? We've heard that, it's in the news, but it's true. So, yeah.
Great, thanks. So what do you guys think are some of the key decision points that companies must consider when they're taking a product to market in healthcare? Ben, maybe I'll start with you.
I would say, have you considered other alternative solutions? Often when we speak to new or startup companies, they get very attached to their baby. And it's real difficult to change and pivot because you get so attached and presuming that's the solution that's going to work. And so it takes a lot to pivot away from that and to be able to adapt to the change and the needs of your potential customers. We see it quite often where they just push a certain direction and are inflexible. So the more flexible you can be, the greater acceptance you'll get from those that's sitting on the other side of the table.
Yeah, Corey, what about you?
Yeah, I was just going to sort of add on to that. We often say, especially for internal innovation projects, fall in love with the problem, don't fall in love with the solution. Especially with early stage organizations. I mean, I'm going to say a lot of what Ben said, but just sort of spin it in a little different way. You have to be able to pivot. I think I've talked to more entrepreneurs just over the last 2 years that essentially had to pivot because of COVID, but really fall in love with the problem, really discover what the real problem is while falling in love with that problem, I guess is my two things. I'll just give couple other things and then pass it off to Jan. One thing, back to the quadruple aim, it needs to improve the experience. It needs to be simple to understand. I kid when someone comes to me with a complex issue or a complex solution to something, and I said, can you explain it to your next door neighbor's grandmother, what you're trying to do? Like, you have to simplify what you're trying to get across to whoever it is. Back to the busyness of healthcare, especially leaders in healthcare, they often don't have time to read a 12-page document. It has to be, as short as a Twitter, post at this point, just to at least get the interest. You clearly have to do the homework behind the scenes and have all that work to show that your product does what it's supposed to do, but be able to really simplify your message. Yeah, I think those are the big things.
Yeah, I think, really hitting on what is the problem you want to solve and refining your elevator pitch and making sure that and it's okay to have more than one elevator pitch. So as you're deciding who your audience is, I think the other thing is what will it be your go-to-market strategy? So if you're going to be a direct-to-consumer, or if you're going to go to the payer, or if you're going to go to the health system, or if you're going to go to some other business, you really got to understand the current state of market pricing. You got to understand. So if you come in and say, well, I want $100 per patient per visit, and the doctor's only making $50, you're not even going to get any further than that. So really think about those things ahead of time as you're building your product and looking for solutions to solve it. Think about how you're going to approach the market. So I think that's just a little bit of things I've experienced personally as we've been building startups and Aspire. But so Jan, actually, I'm going to move on to the next one. I know you have a lot of information. The next question is around talk to us a little bit about the HIPAA and IS security review process that companies that you put companies through as they come into your projects. I know you live this on a day-to-day basis, but give us some insight to what does that look like?
Yeah, sure. So any vendor that comes through Penn Medicine, we go through a process with IS security, and that process involves if your product or service collects data, stores data, sends or receives data, you have to go through this review process. And this review process is just to ensure that the data that you are collecting from our patient is safe and secure. So it's wise to have somebody from your company who understands IS security and HIPAA, privacy policy, to be able to speak and also fill out this form with our IS analysts, our security analysts, because they're going to be asking questions of what does the network diagram look like? if you have a device that's going to be housed within our facility, is it going to be within the firewall? How many users will have access to this? What is your login process? Do you have single sign-on? Do you have two-factor authentication? If you have a website and there's a form, you collect data, the security team would do what's called a vulnerability scan, do a site penetration so that kind of mimic what hackers would do to see if any of the data could be exposed. So this process could take anywhere from 2 to 4 weeks. It's a back and forth process. Again, it's wise to have somebody from the company to have this type of knowledge, whether you hire them full-time, part-time, or even in a contract basis.
Yeah, and Ben, what about on the payer side? You know, are there any things legally, contractually that come up as you're looking at HIPAA and IS security?
Yeah, usually the first document we start with is an NDA or a non-disclosure agreement, and that's really what are the rules between having the discussions between our entities, and what can you do and not do. And it really puts protection so you can have opening conversations. And then as we progress, if you're going to share data, we would move into something called a BAA or Business Associate Agreement. And that really outlines what you're going to be using data for, in what situations can you have it, who can receive it. And so we go through a negotiation and the construction of a Business Associate Agreement between the two organizations for the flow of data. As an insurance company, you know, our main goal is to mitigate risk. And so we house a great deal of highly sensitive information, you know, people's health records, credit card information, you name it, that's considered really sensitive, and we probably house it. And it's really bad for our organization, you know, from a number of things, state regulations, federal regulations, and just being seen by the public when, you know, that information is used incorrectly, and not even unintentionally. Sometimes it's being used. You know, somebody slips up and puts some PHI in an email. That all comes back, and there's penalties that get paid out, and sanctions and fines if we don't adhere to HIPAA compliance.
And then Jan, what about if there's like medical devices or other types, are there other reviews outside of IS that vendors have to go through if they're something beyond just an app or a software?
Yeah, so typically, I mean, we go through the same process as what Ben just mentioned with having a BAA or Business Associate Agreement as well. So the process is, let's say the startup has a good relationship with somebody within the organization, and that stakeholder is ready to roll, to implement the product or service. So the first thing that we ask is to have some type of proposal or service agreement. So within the proposal or service agreement would outline the terms and conditions. So what are we receiving? Is it a device? Well, how much is it valued? Is there going to be training for this device? If this device is, how much is, I think I said how much is it value, but if it's broken, then who's liable to fix it? Back to your question of being like a biomedical device, we also have a department that would review if it would pass our standards. So there's a separate process to go through that as well. We have our legal team review the proposal and also service agreement. But then we also have our risk management team looking at the liability. If the device is broken, or if somehow the patient gets injured, using a device or there's misinformation, what are we liable for? And then, and also depending on how the proposal is written, if you're looking to collect quality data, if you're trying to prove a hypothesis, or if you're trying to use the learnings from the pilot to publish in a journal or an article, then that's a whole different a set of processes that we have to go through our research department. Actually, it goes through our IRB, which is the Institute of Research Board. So yeah, it's a small or a simple pilot could be anywhere from 15 patients to 1,500 patients, but the process of going through implementation is exactly the same. I still have to reach out to all these various departments, and it could take anywhere from 3 months to 1 year to get a product rolled out in a health system like ours.
Yeah, and I think there's also a difference between, again, going with your go-to-market strategy. So if you're an app like Calm and a provider may just mention, hey, there's a free app that you can download, that's not necessarily the health system or the payer making the decision that this is part of our core offering. And so as soon as, you know, it becomes part of a pilot that is sponsored and endorsed by either the payer or the health system, legally and contractually, I know Ben and I've had this conversation this week, it goes up. And so you have to make sure you understand, if you want to play in this higher market where you could get, you know, a health system or a payer to be your customer, that also comes with these higher level of scrutiny from a security and data perspective. I will say also Apple and the App Store and the Google Play Store, they do also focus on trying to, if things are considered medical, they do have their own different levels of scrutiny that they have to go through in order to get published. There was a period where if you mentioned the word COVID in your app, you kind of got blacklisted until you got through a 2 to 4 week Apple review or Google Play review during the last 12, 18 months, as compared to typically they can turn around new apps within 24 hours. So just depending on where you're going and what market is, you're going to have some protocols and security that you need to focus on. Well, let's move into the next question. Corey, I'm going to start with you. What are some of the competing priorities that exist in healthcare adoption when you're pitching to a payer or a health system, or what if they're both in the same room, like in our scenario? So.
Yeah, great question. Yeah, I think Ben touched on some of that earlier. We had an example where Ben actually used the example where we had a vendor come to us and say, the payer was not, Ben and his team were not in the room, but they came to us and said, we can make you all this revenue by the product that they offered. But, in typical healthcare, how healthcare has been for a long time, us making revenue means more cost for Ben. So, the good news is that we're trying to move more and more to value-based care, which is, I think, a lot of the great vision of our leaders setting the Smart Health Innovation Lab up is that, we should all be aligned with trying to get the best care for the patient, and then, payment of that will come second, right? But to sort of just tie together your original question, around competing priorities, and I mentioned this a little bit earlier, but I just want to touch on it again. A lot of vendors come to us, startups come to us with their product really only works if you integrate it into our IT system. And Jan talked a little bit about the process of trying to integrate. And this is a little because of COVID, or a lot because of COVID. Our IT list has grown and grown over time because we were focused on COVID. If you think about it, most health systems had to set up vaccine clinics and testing and all sorts of stuff we had no idea we would need to do before. So we have a long queue of projects that we're now trying to attack. So, when a vendor comes to us and says, integrating into your EMR system is critical for this product or service to work, that's unfortunately it's a competing priority then, right? Because it's competing against all the other ITIS work that has to happen. So I think that's the main point I wanted to make here, but I'd love to hear from my other colleagues on that.
Yeah, Ben, what about you?
Yeah, I absolutely agree with what Corey said. One of the things you should be thinking about is how to move away from fee for service, if at all possible. It's antiquated at best, and really, if you know anything about fee for service, it's really just reimbursement based on volume. So the more volume you have, the more revenue you make, and so that puts the payer in a position where they have to deny or limit services or availability, and that's not really what we want to do. That's not the tenets of us in playing in the healthcare space. We want good quality healthcare available to as many people as possible. Things you should be thinking about is how do we give you credit for your product's change or savings that it's creating? We look at probably dozens of technologies and solutions in any given space during a year. Diabetes, for an example, if you have a diabetes solution, how do we give you credit for the change and bend in savings for membership versus a telehealth diabetes program we just put in versus a diabetes management program that we have going on? So how do we differentiate you in the data and can reflect the savings to you? Another place is probably, it works for both the provider and the payer, is around impacts to clinical and operational workflows. So you might have the best product in the world, but if it's going to cause a clinician more time not spending it with the patient, or administratively they have to do more, they probably aren't going to use it, and it's not going to get adopted. And it's the same in the insurer side as well. If we have to significantly change our processes or configure data in a certain way, it'll fall on a deaf ear. So the first thing to do is really think about how your product or program fits into the dynamics of each of the organizations.
Yeah, that's great, guys. Thanks. I think I'm going to move into the next question, and Jan, probably start with you. Maybe you could talk a little bit. So one of the things I think, if you're an entrepreneur, you're unsure of really how to get your foot in the door. How do I get my foot in the door with payer or my health system? Can you talk a little bit about the innovation team's process that you have here at Lancaster General and maybe at Penn, about new ideas and new projects, whether they're coming in from staff members, some things that you guys have set up on the innovation team in order to help facilitate that conversation with the right people?
Yeah, sure. So most of the projects, the startup projects that I've implemented have either come through the Smart Health Innovation Lab or other accelerators that we have relationships with. So I think it's key for startups to have a good relationship with a variety of accelerators. Our contacts at these accelerators, we touch base on a good amount of, maybe every other month. We're involved in if they have any sprints with their program or with other startups within their program. That's how we learn about them. We also hear it through our colleagues, other departments from Penn Medicine downtown as well. So I think having just relationships with those accelerators, I mean, that's how we've gotten to know with most of the startups or the products and services that we're in the process of implementing or have implemented.
Great. Maybe Corey, can you talk a little bit more about on the health system side, if you aren't going down the traditional accelerator route, what are other ways to get into a health system?
Yeah, I mean, I think the easiest way is to find the innovation team at the organization. I would say most larger health systems now have a department or a group called innovation. So how do you find those people? Conferences in a post-COVID world or pre-COVID world, LinkedIn, things like that. But honestly, the people that we hire into innovation departments have an open mind to look at things. A lot of times our leaders in healthcare, they're operational leaders, so they're very focused on the day-to-day fire right in front of them. I mean, I'm not saying that all leaders are not strategic. I'm not saying that at all, but usually their focus is very much on the on the day-to-day, the week-to-week, when innovation teams or maybe even patient experience teams, or if your product is maybe related to consumerism, finding those teams that are sort of looking out into the future, because often your innovation is something that most aren't even thinking about. However, I will say one thing: you need to bring it back to the problem that these institutions are having. So that might get you into the door into the innovation department, but oftentimes the real decision is at the operational leader perspective. So you better be solving a real problem that operational leader has. So those are my thoughts.
Great. And then Ben, any differences on a payer side on how you should approach, and if you have a desire for your product to be used, endorsed, reported by a payer?
Yeah, I mean, I think the most important thing is to find a champion, somebody that believes in your product from within the organization that you're pitching to, right? That can work the channels up and down. There's a lot of benefit from starting at the top or identifying, a CEO of a company, because obviously they can push it down to the organization and dictate that it's adopted. But often it fails because they don't necessarily have the granularity to see the impacts of what that means to the organization. And so it tends to fail on the next layer down. And then there's the other school of thought, the bottom up, where you can probably more easily find a champion that believes in it, but they typically don't either own resources in order to do it, or they're not in a position in making decisions. So they have to go back up in order to gain that agreement and buy-in. And so the timeframes are longer. So like I said, there's the benefits to both ways, but the key is finding somebody, a champion that's going to promote it within the organization. And as always, a program like the Innovation Lab, that you get to speak to people up and down the line in the different varying levels, that's always the best move, I think.
Yeah, I think from a payer perspective, it's really do your research on the payer that you're approaching. So somebody like a Blues plan is going to be completely different than maybe a CMS or a Medicare, Medicaid plan. A Medicaid plan in PA may be very different than New York. So making sure that you kind of, again, we talked about it before, but know your audience, because some are going to be a little more open to those things. I know, Ben, there's been also not just I think you've participated on the payer side, especially within the Blues. A lot of the other innovation labs hold pitch contests, or they do problem guide well down in Florida. I don't know if you want to talk just briefly about like how they structure some of their calls for companies.
Yeah, generally they're looking for a problem. So collectively, we the Blues, if you're familiar with them, we talk a lot amongst ourselves. One of the great values of getting in with one of the Blue plans is once you get in with one, they often promote it with their sister plans, and each Blue plan is unique and are owned separately. So each of the 35 are independently owned. It brings a bit of challenge sometimes because their policies may differ. So once you go into one Blue plan, it's one Blue plan, and everyone is probably a little more unique, although we do have generalized guiding principles, and processes are very similar. They can vary depending on where you are in the country. And so I think if you were to get into a Blue plan, it's a good value proposition for you because of the way that they communicate. But like I said, there are challenges because you can't assume that when you talk to a Capital Blue Cross, it's the same as an Anthem Blue Cross, because Anthem is serves multiple millions of people, and they're structured much differently.
Yeah, and then from the VC perspective, I think it's also, as you're building out your network and trying to find investors, looking at people that are currently investing in healthcare. So there's the Blue Venture Fund, the Sandbox out of Chicago. They're kind of the deal sourcing for all of the Blue Ventures, and so they're the ones going out meeting with companies, trying to understand what their technology does, because they're listening to the collective Blue plan of we need to solve a problem in diabetes. So focus on venture capital groups that are really investing in technology that is similar to what problem you're trying to solve. And then just look at, some of the other types of, Jan mentioned the accelerators, so like Matter Health in Chicago, or there's the Techstars across the US. Try to figure out which one is offering a program that might allow you access to those experts. And again, we all share ideas, and so whether it be Plug and Play in Cleveland Clinic, there's ones down at Johns Hopkins, so we kind of keep this network of ideas of companies. So finding the right person, again, no matter who it is, to be your champion and kind of speak on your behalf will get you pretty far. So I know, go ahead, Ben. Yep.
Just chime in on that. We do have monthly innovation calls with the association, with our peers. We do share information, and we invest not only within the Blues, we participate in the Sandbox Blue Venture Fund, but we have other funds that we participate in, and often, even if we're not using a company, we'll nominate them or tell these venture capital companies about opportunities that they may have to be able to invest in new startup technologies, even if we can't take advantage of them ourselves.
Yeah, and we had a question that came in from the audience. So it looks what types of innovations do you think get the most traction? Anybody want to take that one? Go ahead, Corey.
One that goes after a specific problem?
I would agree with Ben. I think when you have a very distinct problem and the solution solves it, it's a no-brainer. Those get the quickest. I think the example you gave earlier in the call about teledermatology, I mean, we all came together and said, hey, I think we have a problem about getting patients in a dermatologist. So we knew what the problem was. It was an access problem. And then, we found technologies that would meet that. But I just want to mention just one other thing. I think from an outsider perspective, you think that the venture capital and the startup world is like vast. But I think to Kim and Ben's point, it's rather small, actually. When we have a need, we often go to our friends in the community and say, hey, do you know of any teledermatology products that do XYZ? And it's easy to get a handful of a list of people that they know in the industry. So I think it's just so important, just meeting people, and it's old school networking, as well. So probably answered part of your earlier question as well with that. So
yeah, that's great. I think and from innovations that get the most traction, I think there's a definition of how fast you can get that traction, right? So Jan, firsthand, software, external things that are low touch, like a text app or something like that, that may be more easily adopted comparative to a new pacemaker that you're going to implant in a surgery. And so where do you see the innovations in your team that are getting the most traction?
I can talk about innovation that don't get the most traction.
All right, let's go the other way then.
It's easier for me to address that. I know, like, through every demo that I sat in with our key physician leaders and with operation, the number one question that we ask startups is, do you integrate with our EMR? And if so, that's awesome, right? But the caveat is when there's integration, it utilizes resources, a lot of IS resources. And we talked about like all the competing priorities within IS as well. But you're gonna have to learn how to pivot or change the workflow a bit and maybe not do full integration, maybe just do like a hybrid approach, have one section of a workflow be a little bit more manual and not have full integration, or use a third-party integration tool to help reduce the process or the implementation. Another thing is doing research on what EMR that health system is using. So does that EMR also provide the same product or service that you're offering? Because if it does, most likely you're not going to get any traction with us, because we're married. Most health systems are already married to the EMR system that we've invested in.
Yeah, that's great.
Yeah, I think Rufus's question and Jan's answer sort of match up. I don't know, Kim, if you want to touch or just, I don't know if you can see it or not.
Oh, sorry. Go ahead, Corey.
Yeah, sure. So Rufus, great question. So questions about how do clinicians handle all the different clinician portals from various startup companies who promise communication with providers? Does it lead to overwhelm and more burnout? Or are clinicians generally happy to incorporate new products in the workflow? And I think to Jan's answer of what startups don't work, any product that comes in or service that comes in that we can easily see is going to add more work to the overburdened clinician already, specifically on communication with patients, either real time or asynchronous. It's a non-starter. We're trying to solve that problem, frankly, for our providers now. There's concepts called inboxologists, and team-based care has been a concept that's been around for some time now, but essentially it's how do we take some burden off our clinicians with communication specifically. Our average physician spends 4 to 6 hours a week uncompensated time responding to portal messages, and we're trying to solve that. So any product that comes in that puts more on is a non-starter.
Yeah, that's great. We did have another question about, have you seen any innovations that have been boosted by the pandemic? Anything, obviously we've all kind of probably experienced some version of telemedicine, whether it be a video chat with your provider, or text messages or emails inside of portals. But was there any other standout technologies and innovations that you saw in the last, 12 months, 18 months that COVID kind of presented a need for?
Yeah, I would say what we've seen is a change in site of service, right? So things that were typically being done in a hospital setting are now being moved to an outpatient setting, and outpatient settings are being moved to, urgent care or a center.
Or home.
Or home, right? And then the home care services now are telehealth services. So, there's that dynamic shift in bringing care to a lower level of, what do you want to call it, Corey? not lower level care,
Acuity.
but a lower acuity. Yeah. So, there's definitely savings for us in that. So we're all about seeing that, but it also has an absolute impact on our payers, right? Or excuse me, on our providers, because it's moving people out of what their care settings they're typically used to providing. So they're adapting as well to that.
Yeah.
Jan or Corey, anything else?
Yeah, I was just going to add on just, to the whole text messaging, some of the stuff that you mentioned. Trying to get a patient out of a home. So just use a COVID patient that doesn't need, in the past, the hospital was really the only path for them. Pre-COVID, for similar acuity, the hospital was the only place. But, using artificial intelligence plus text messaging to check in on patients in an automated fashion to make sure that they're still doing okay. I mean, the interesting thing with COVID was that a patient may have been okay in the hospital, okay enough to go home, and then for whatever reason, the disease progression would just, quickly go in the wrong direction. So having a method to be able to communicate with that person on scale was implemented very quickly. And again, we probably would have took years in the past. We were always talking about AI and being able to remote monitor patients somehow, but we essentially were able to do it within, weeks.
Yeah, and I mean, one of the projects that actually we jointly worked on was the screening. So the health systems had to stay open. And so what technology could we come up with that could take your temperature, ask you those COVID questions? And so we did some prototypes, we did some back and forth, we did app testing. And so it was a need during that moment. But now as we've shifted, it's some of it became almost security theater. So you were taking a temperature, but at some point and asking a question. I mean, right now, are you adding vaccines and all that added complexity? So those first few months after shutdown, that was a very critical need. So there's a period where your innovation you may have timed the market perfectly, but then 3 months later, there's no more need for your product. And so you have to then pivot. And we saw some companies that came back to us that they were working on certain things and they're like, nope, we're now developing a rapid at-home test for COVID. And that's what we're heads down on because that was, May of last year. And so having that ability and that flexibility to adapt really was critical during the pandemic. So let's see, another question that came in is, can you talk a little bit about how data impacts the adoption of solutions? Jan, you talked about how integration is really difficult, but for our teams, the predictive models and advanced computing is where we see innovation. Is there any hope for predictive modeling and data being able to, or having your data be accessible, de-identified? Where do you guys stand on the layering of that? Corey or Jan or Ben, anybody that wants to jump in on that?
I hope Jan takes this one.
Yes, I'll take this one. I love this question because it's pretty timely with where we're at with our innovation tech scan project. Predictive modeling, I mean, we've internally with LGH and also Penn Medicine as a whole, I mean, we see this as the future. And yes, it is hard to get systems integrated within our EMR because of IS resources, but don't let that deter you from continuing on with your product if it uses AI computing, advanced computing. But yeah, we do see predictive modeling as a way to help with our workflow, our existing workflow. So anything that could help reduce time for our patients to go through the patient workflow experience or reduced timing for our staff is a win. So yeah, I mean, we're data is a huge component within healthcare. I mean, we have a business intelligence unit that is very protective of the data that we have. Not everyone, like I can't, like, just because I work in a healthcare organization doesn't mean I have access to our EMR. You have to go through a separate process to be able to collect data and what is the business purpose or use case to even see that data. But yeah, I mean, to answer the question, like, it is part of the future. In fact, I don't know if I'm able to share this, but I mean, it's on YouTube, so it's out on the internet. But if you like search digital twins, that uses predictive modeling. We're actually in the process of implementing that at one of our hospitals in downtown Philly for the emergency department. So that's exactly what we're looking to do to implement those type of technologies within innovation.
Yeah, that's great.
Yeah,
go ahead, Ben.
Yeah, I would just caveat that based on what Jan had mentioned, organizations are very protective of their data, right? Often that's what sets them apart from somebody else is the types of data that they have and how they use it. So it's often difficult for you to get access to it, not just from like the HIPAA stuff, right? That's one layer of trying to get access. What are you going to use it for? Who's it going to go to? There's a whole nother layer of the competitive advantage of having access to certain types of data. And, you know, health systems data is slightly different, sometimes more different than the payer. And so you'll run up against that when you're asking like, hey, share your stuff with me so I can prove that my product works really well. You'll be fronted with a lot of resistance probably.
Yeah, and I think I was just finish that out. You know, I think there's opportunities both operationally and clinically for predictive modeling, whether it be inside a payer and you know, their coverage of services, but also operationally, you know, how do we streamline somebody through an ER? But if you are going to be trying to access data versus contributing to data, there'll probably be a length of time when you're trying to complete the contract. So the more data that you want access to, I've find that the more the lawyers want to be involved and the more the time it's going to take to actually get implemented. So think about that, and it may be something you have to weigh the value of the data of ongoing predictive models comparative to a static model that you may have developed with research data sets, and just that may limit your time or impact your time to market. Ben, maybe you can take this next one. You know, do you feel that the pandemic hurt or helped our journey towards value-based care?
I mean, I'm pretty neutral when it comes to it because I think everybody's been so pulled in addressing the pandemic itself and how do you change and implement things that we really hasn't necessarily directly impacted reimbursement structures at this point. You know, I would hope that some of the changes in the technology and such would naturally advance value-based programs. And I think just the market itself, irrespective of the pandemic, is pushing towards collaboration between health systems and payers because of the push from government entities and demands from customers to reduce cost. It's naturally going that way, but I wouldn't say that the pandemic specifically has had an impact directly that I could see. I don't know, Corey, Jan, if you see differently.
Yeah, I mean, I would say the only thing is that so my definition of value-based, this is Corey's definition of value-based care is doing the right thing for the patient and not caring how you get paid for it. I think that COVID allowed us to try and test a lot of things because we just knew it was the right thing to do. So I hope, I'm not sure if it has, but I hope that it pushes us forward to more value-based care, because we did try new things and they did have real outcomes, and it kept people out of the hospital. It kept, whatever it was trying to do, we had to test it. We had to do those things. So I hope it pushes us forward to value-based care.
Yeah, I think the only thing we need to figure out is, and I think we've gotten better, but it's all the people that put off the preventative care, and trying to now take that and so with our teledermatology solution, a lot of people didn't go get skin screenings, but now we're trying to find a way, can we offer that at home, or can we offer that in a retail setting at the employer group? Because people, the pandemic made people realize, like, I don't have to go to the doctor for everything. There are other ways and other care settings that things can happen. So, I would kind of be neutral as well. I would hope that we have opened our eyes to some new opportunities. But let's see what else we got going on. So much of innovation comes out of research. Are most payers or hospital systems supportive of participating in research partnerships outside of the academic medical centers? So Ben, how do you guys at Capital, do you participate in research? Do you contribute your data through the association?
I would say we're probably 2 or 3 layers deep. We share our information with the association that actively participates in all types of research, market research, clinical analysis of tools and products and services. We tend not to do direct research. We're more reliant upon the downstreams of our participation in those programs versus direct involvement ourselves.
Yeah, Jan or Corey, what about you guys? Is
Jan,
that usually done with Parent Pen, or?
Yeah, Jan, do you want to take her? I'm happy to talk a little bit about it. You probably know more about our research institute, but I'll just start. So yeah, I would say most non-academic medical centers that are larger, like us, have what we call research institute. So we'll often do, we'll be a site of a research study that might be at, frankly, Cleveland Clinic or Mayo or Penn downtown. We also do some of our own research as well. I would say the smaller the size of the system, the less likely research will be done at those organizations. The great thing is, just a quick web search on any health system website will quickly tell you if they have a research institute, and usually they have contact information directly on those websites as well, who to reach out to.
Yeah. All right, great. Let's wrap up then with just kind of what are your top tips for startups? So Jan, why don't you give the team some tips from your perspective?
Do your research when you're pitching to a health system. Research who the audience is, what EMR they're using, how you can help reduce their time and their work, and then also, I'm sorry, I'm getting a phone call right now. And also invest in having someone who is knowledgeable in IS security, since you're going to have to go through that process as well. Understand how to protect the data that you collect and store. And also the ability to be agile and nimble, and understanding the problem of the audience again, and if it doesn't fit their problem, what are the ways that you could help pivot your product to meet their needs and resolve their problems.
Great, thanks. Corey, how about you?
I'll try not to repeat any of Jan's. Good list. So a few things. So one, get a clinical if you're not a clinical person, get a clinical mentor, get someone on your board, you know, that can help talk to your product. A lot of times clinicians want to talk directly to clinicians, and there's a level of respect there. So don't be offended, but find someone, find a friend. I said this earlier, but simplify the message. You know, the elevator pitch, the Twitter thing, just whatever it is that you can simplify your message as much as you can so everyone can understand it. Because oftentimes you're talking to someone like me who is not clinical, but will help you get to the next level. So if I can understand it, I can then get you to, you know, that surgeon that needs to listen to your pitch. And then lastly, invest in a website. You probably during the session, you may have Googled our names or searched our names. We're doing the same thing. When you come to us with a product, we're looking at your website. We're trying to see if it's, you know, to see if there's some, you know, has good information on there and explains your product well. So, you know, invest some money on that. That's, you know, that's out there 24/7 being your sales pitch for you. So thank you.
And Ben, what about you?
I would say fall in love with your idea so much that it gets you through the tough times, the denials, the, you know, being left at the door, because that is a lot, and it happens a lot with startup companies. But don't fall in love with it so much that you're not willing to do things differently or to pivot. And I would say, if you're the innovator, if you're the idea person, stick to being the idea person or the innovator and work on that, sharpening that tool, making it the best. But if you don't know the business side of it, find somebody that can do the business side of things for you. Often we see entrepreneurs that are really, really great in solving for problems and coming up with solutions, but they can't speak the business terms that they need in order to advance it into the market. And then reevaluate often against what's going on in the market, your competition, and what the trends are. And like I said, biggest thing is be flexible.
Great, thanks. And then I'll just add a few, you know, recognize that there are experts. Don't always try to be the smartest person in the room. The biggest thing you can do is listen. If you get access to anyone in the healthcare space, anybody that'll listen, that will hear your pitch, listen to their feedback, and it's often really helpful to have another person in the room, because what you're hearing when your adrenaline is pumping and you're pitching is often may not be what you're not going to have time to write down the notes. So just make sure that there's somebody else that's there that has your back that can also kind of help guide you. I think the team mentioned it, flexibility, you know, fail fast, iterate often, and really, you know, Corey talked about websites. The other thing I would focus on is if you are in a capital raise or you're looking for fundraising, you know, make sure your profile is updated on Crunchbase. As soon as you form that company, get things updated on Crunchbase and PitchBook, because that's where, so we have a couple different spots where we look. So if I can't find you out there, I then think you're super early and you have no money raised when you may be a little bit further along. So I think that's it. You know, I hope we imparted some wisdom for you today on innovation, and I hope we didn't scare you away from it. But I think it is really exciting, and if you have that passion for solving that problem, you know, there are people like ourselves that are out there that want to help you. So thanks so much. I'll turn it back over and see if there's any other final questions.
I don't have any final questions, but I do want to thank you guys so much. This has been incredible. And a lot of what we're trying to show our student teams is that they need the relationships, just like you've been reiterating. And these are some of the smartest people in healthcare that are on this panel. So I'm really excited to introduce them to you, and hopefully that relationship will continue. Thank you so much, guys, for joining, and we'll talk soon, I'm sure.
All right. Thanks, everyone. Have a great day.
Yeah.
Thank you.
Bye.